All right. Good evening, everyone. Thank you so much for joining us. My name is Elizabeth Campbell. I am a orthopedic, sports, and pelvic health physical therapist with Limitless Physical Therapy. I'm excited to present on menopause and pelvic health tonight. It is the first of many presentations that I'll be doing throughout the year. My goal is to host about one a month, with the first 2 to 3 quarters focusing on pelvic health related topics. Pelvic health and pelvic health physical therapy is rapidly advancing, and we are getting a lot of new and great information. So I see these workshops as a way to really disseminate and educate our immediate communities, and hopefully that spreads throughout families, friends, colleagues, and so on. So I wanted to choose menopause as our topic tonight, just because it's it's commonly misconstrued or not well understood, and I think it deserves more attention. I think it deserves more dialogue, and I think women in general just are owed a bit more awareness and education about what symptoms and treatments in menopause consist of. And we'll go over the role of pelvic physical therapy during the perimenopause and menopause transitions as well. So menopause has the worst PR campaign in the history of the universe, because it's not just about hot flashes and night sweats. This is an awesome quote by Rachel Rubin, who is a urologist and a sexual health specialist. And I think many women throughout their lifetime can kind of feel the weight of this statement, because what we experience is far more than some of these simplified symptoms that are often associated with these conditions. So I'm hoping to open things up today with a lot of these different topics we'll cover. So we're going to talk about menopause, what it is, the symptoms, the kind of underlying hormonal physiology of perimenopause and menopause. We're going to talk about changes that occur locally in the vagina, and what are some different treatments and guidelines for some of these changes, and how they impact our function and quality of life. And we're going to talk about sex and why sex doesn't and shouldn't have to end with menopause. And then we're going to talk about kind of the fundamentals of kind of winning through perimenopause and menopause. So optimizing our sleep, optimizing our movement, our nutrition, our stress management, and kind of what are the ideal pillars or goals and marks to hit for these different areas, and how they're going to help us not only in the short term during perimenopause and menopause, but also in the long term, because we want to optimize our health and longevity. So the kind of big component or major kind of function that we want to think about when it comes to our reproductive cycle is the concept of hormone balance. Perimenopause and menopause is a time where our hormone balance starts to become imbalanced. So we have a few key players here. So we have estrogen and progesterone, our two female sex hormones. Estrogen is a hormone that's going to promote growth in our tissues, driving breast development, pelvic development. It has a tremendous impact on cardiac and bone health, as well as our muscle and tendon health, and it plays a pivotal role in maintaining the lining of the uterus. Progesterone is the hormone that keeps estrogen in track. So it is functioning to maintain an optimal quantity and quality of growth. So a nice analogy to think of here is that estrogen is like the fertilizer we put on our grass, and progesterone is the lawnmower that comes behind later on to kind of clean up, cut things to the perfect height, and keep things trim and neat. So these two, progesterone and estrogen, are kind of our key hormones that ideally maintain a nice balance and have tremendous impact across our entire body and multiple systems. Um, our other key players are testosterone, cortisol, and insulin. Testosterone, women generally have about 1/10 to 1/20th the amount as our male counterparts. But this is a really key hormone for brain function, as it's going to help with clarity and cognition. But it's also a pretty important role in libido and sexual health, as well as our muscle and bone health. So when there are declines in females' levels of testosterone, this is going to have an impact on our quality of life. So ideally, through our lifespan, we maintain a good reserve via good body muscle mass. Cortisol is the other hormone. This is our human stress hormone. So this is produced by the adrenal glands and is released when we experience a stressful event. The stressful event triggers the release of cortisol, which provides energy, increases our alertness, and response to whatever stress is occurring. So this is a very revolutionary or historically was a very important hormone. If we can think about hundreds and hundreds of years ago when humans were, trying to survive day to day, stress and cortisol were key in that survival. It allowed us to tap into our energy storages and have the energy and ability to react and respond as needed. In present day, our stressors are a little bit different, but this action and this physiological process is the same. So generally, when we experience stress, cortisol is released and we are triggered to kind of consume food to create energy storages so that we can handle whatever stress is coming. So we're going to kind of talk about the key role that cortisol has in perimenopause and menopause. And then insulin. Insulin is a hormone that allows our cells to absorb glucose from the blood. This is going to help regulate and stabilize our blood sugar levels. This really controls how much glucose is in the blood. And again, this is going to be a key consideration in perimenopause and menopause. So we'll start first just reviewing the female cycle. So day 1 through 5, if we look over at this chart, is the kind of all the way to the left. At the very top of this chart, we see a demonstration of what's occurring in the ovary. Beneath that is a graph of body temperature. Beneath that are our pituitary and ovarian hormones. And then beyond and lower to that is kind of what's occurring within the uterine lining and the blood perfusion. So at day 1 and through day 5 is considered the beginning of our cycle and is when we are actively bleeding. So this is when our uterus is beginning to shed its lining and we are having active bleeding. And you can see in that region of ovarian hormone that our estrogen and progesterone are relatively low during this 5-day period. Leaving that 5-day period, we go into the follicular phase, which is when the uterus is preparing for ovulation and fertilization. So we see a rise in our follicular or our follicle stimulating hormone and a steady rise in estrogen. Again, these are occurring to prepare the follicle and also prepare the uterus for fertilization. Estrogen is going to peak right before ovulation and then take a steep nosedive. And at that kind of mid-cycle mark, that 14-day mark, is when ovulation occurs. This is an important part of the cycle, because the ovulation that occurs and the release of an egg is going to trigger the ovarian hormone progesterone. So as the body is trying to determine if it is pregnant through that luteal phase, progesterone is high, estrogen is relatively high, and our core body temperature rises. And you can see down in that lower aspect of the table that our uterine lining is very thick and heavily perfused with blood vessels. Once our body determines that we are not pregnant, there is no fertilization that occurs, both levels of progesterone and estrogen will fall, and our body will prepare to go into the next bleed and shed the uterine lining, and then the cycle kind of happens all over again. So this is that kind of natural rise and fall and kind of key balance of how these hormones play off of one another. When perimenopause occurs, is typically the time when the uterus is starting to lose its capacity to ovulate. So it becomes inconsistent or unable to release an egg. So we have what's called anovulatory cycles. So we will still have that rise in estrogen, but when it comes time for the release of an egg and fertilization to occur, we are not getting the ovulation. And so progesterone is not triggered. And so we just maintain a higher relative level of estrogen. So this is important because we need to think back, right? The key here for reproductive health is that hormone balance, and specifically for our considerations today, that balance of estrogen and progesterone. So when we lose that ovulation, we don't get that rise in progesterone to meet the rise in estrogen. So now we start to have a little bit of a divide or imbalance that develops. So it's, I think, really critical for all women in their reproductive, for their reproductive health and just personal health, to be tracking their cycle so we can know what our patterns are, what our common symptoms are, our tendencies are, and we can see that relative to the rise and fall of our hormones. So then when we may be nearing the age of 40, 42, 43, 44, closer to 45, when small changes start to occur symptomally, we can kind of have an idea of what we're experiencing versus kind of that guessing game of, or kind of, just feeling like you're alone in the dark, kind of guessing that something's going on. So tracking your cycles, I think, is incredibly beneficial. And there's so many resources out there for free that we can access these days to help us do so. Some other things we can kind of be aware of to know relatively where we are in our cycle is our body temperature, and we can also observe our cervical mucus. Blood work for the diagnosis of perimenopause is really not indicated, just due to the fluctuation nature of our hormones to begin with. So blood work is really found to be inconclusive. The only test that can be helpful if you are a woman under the age of 45, is to get your FSH levels measured. And why that is a possibility is because your pituitary gland wants progesterone. So it is going to work very hard for ovulation to occur. So FSH is that hormone that is trying to stimulate follicle development. So your pituitary gland is going to push out a lot of FSH to try to keep things going, keep ovulation occurring, to get that progesterone it wants. So if a woman under the age of 45 has her FSH levels evaluated and they are over 40, that can be an indicator of this pituitary gland activity and could indicate that you are in perimenopause. So perimenopause, it's 5 to 15 years leading to menopause. So we have relatively high FSH, high estrogen, low progesterone, right? So that imbalance is now in play. Both are gradually going to start to fluctuate down, but still there's that relative poor ratio of estrogen to progesterone. So common symptoms that one can experience with excess estrogen is anxiety, depression, insomnia, breast tenderness, heart palpitations, hot flashes, night sweats, heart or headaches, heavy cramping, and irregular periods. So we are going to kind of combine some of these symptoms, such as heart palpitations, hot flashes, night sweats, headaches, as or a blanket term called vasomotor symptoms. So symptoms related to cardiovascular changes due to excess estrogen. And I think an important thing to note here is that heavy cramping and irregular periods. So during perimenopause, women are still going to be actively bleeding, and actually they can experience, it's common to experience an increase in heaviness, an increase in cramping and discomfort, right? Because remember that estrogen level is high, and the estrogen is thickening that uterine lining, but we don't have that progesterone to come behind and kind of keep it maintained. So then the body has to work a good bit harder to shed that lining. And to do so, it can lead to some of these symptoms of heavy cramping and irregularity with periods. And then menopause is going to be the time when you have gone 12 months of being period free. So 12 months continuously without menstruation. And when you've reached this mark, our hormones have fluctuated steadily down. So now it's a period of low estrogen and low progesterone. So common symptoms here, insomnia or difficulty sleeping, musculoskeletal pains and aches. So joint pains, muscular pains, tendon dysfunctions, arterial stiffening, genitourinary symptoms of menopause, which is a term for more of the local vulvovaginal tissue changes that occur in a woman's vagina and relative to her pelvic organs, brain fog, and then we have insulin resistance, weight gain, the development of adipose tissue in the abdomen, and systemic inflammation. So we have low estrogen, low progesterone, and higher levels of cortisol and insulin. So the kind of first big topic that we're going to discuss is these vasomotor symptoms. So the hot flashes, the night sweats, the day sweats, dry mouth, heart palpitations, this sense of hot flash or rush, breathlessness, dizziness, nausea. These are symptoms that about 88% of women are going to experience. And though they vary in intensity and frequency, they're generally going to occur for most women. And they will generally be kind of maintained for about 5 to 7 years and then slowly dissipate and decrease in menopause. So these are symptoms that are occurring consistently but will gradually improve. Risk factors for these vasomotor symptoms: surgical menopause, obesity, smoking, anxiety, and depression. So these symptoms should really kind of be um, kind of triggers or flags for women to be aware of, because they are indicators of our cardiovascular system, and these symptoms don't just stay in perimenopause and menopause, right? Cardiovascular health is lifelong. And when we lose estrogen, we are losing a hormone that has high cardioprotective features. So estrogen is going to improve our good cholesterol, reduce our bad cholesterol. Promotes a good balance between clot formation and breakdown. It's going to keep our vessels nice and smooth and relaxed to dilate for optimal blood flow. And it's going to soak up free radicals or damaging particles that might be in the blood. So really, in menopause, when our estrogen and progesterone take that dive and kind of drop below about 30 picograms a milliliter, then we are going to lose these effects, and this is long term. So this is a time in perimenopause, menopause, or leading up to perimenopause to kind of grab the bull by the horns and commit to some good cardiovascular health practices, because 1 in 3 women in menopause will be diagnosed with cardiovascular disease. So this is really a big topic we're going to discuss, both from a pharmaceutical standpoint and what's recommended, and also what are those specific lifestyle changes that we can implement right away and that we have control over. So the gold standard medical treatment put forth by the Menopause Society and the Societies for Urology and Gynecology is the recommendation for estrogen-based hormone replacement therapy. For those it is deemed safe and appropriate, combined with lifestyle changes and commitment to prevention. So how do we move? How do you eat? How do you handle stress? And how do you sleep? These are kind of the standards that we're going to review, that we will want to try to optimize to the best of our ability. Because not only are we going to see that they are going to improve our health and our symptoms relative to perimenopause and menopause, but they are also going to help us make incredible gains for the long term. So recommendations for cardiovascular exercise is about 150 minutes a week of moderate intensity exercise. This is going to impact heart health. It's going to improve mood. It's going to reduce obesity, improve those vasomotor symptoms, improve hormone balance, and reduce cancer risk. There's also good recommendations for 20 minutes of high intensity exercise. This has been correlated with reduced morbidity across a number of systemic diseases. So if we think about intensity levels, how to know what intensity we're in. I think a good marker measure of high intensity is a level of exercise and exertion in which you are unable to conversate during, while moderate intensity would be exercise or activity where you can, lightly maintain some conversation, but not steady conversation. So that high intensity should be, a physical, level that you need extended periods of rest and you need time to recover and you feel that pretty exceptional stimulus. Strength training is recommended 2 to 3 progressive training sessions a week, where you are working through a series of cycles with progressive overload to stimulate changes within the muscular tissue. This is not only going to improve our local muscular system, so our muscles and our tendons, but it also has a significant impact on our bone health. In those first few years of perimenopause, with the dramatic changes in our hormones, bone loss, rapid bone loss, is a significant concern and highly occurrent. So maintaining good exercise base, maintaining good muscular base, and keeping up with impact exercise is going to help us maintain our bone integrity. Not build new bone. Typically, after about 30 years of age, we have reached our peak bone density, but our goal is to maintain what we can. So obviously, strength training is going to see that benefit for bone health, but it's also can reduce vasomotor symptoms up to 50%. It's also going to help reduce morbidity, and it can have a reduction in cardiovascular disease, reports from 40 to 70%. We see about a 30% reduction in metabolic syndromes, 32% reduction in cholesterol, and there's a pretty excellent correlation between leg strength and brain health. So high cognitive function, mood, and memory capacity. All right, and then meditation and mindfulness. So meditation and mindfulness has a significant antihypertensive effect and it's been reported to reduce vasomotor symptoms, some studies reporting up to 52%. So practices such as yoga, paced breathing, thoracic spine mobility, and meditation are a few of these examples where we can see this incredible impact on our vasomotor symptoms, but also our stress management and levels of cortisol. So we see a good correlation here between these practices and improved quality of life. So it's just so important that we prioritize our mental, emotional health, right? That we're kind to our soul. We are kind to, our deeper inner being, what's between our ears, because all these systems play off one another. And if we just do the exercise really well, that's good. But high stress, poor sleep, poor eating is going to keep some of these other processes in place. So it really has to be a conscious effort across all of these domains. Nutrition, what we eat, what we put in our bodies. It is more than just calories in and calories out. What's the key here is the inflammatory profile of the foods we eat. So there's pretty conclusive evidence that supports a plant-based whole food diet. And the impact here is huge. So we see reduced heart attack and stroke, improved blood glucose levels, reduced insulin resistance, improved cognition, reduced risk of breast cancer, stabilized and improved vasomotor symptoms, reduced body fat. So pretty compelling. And then hydration, right? That's to the other high domain. Are we achieving 60 to 70 ounces of water? If we're exercising vigorously, are we achieving maybe 90 to 100 ounces of water? uh, Alcohol consumption. So, alcohol has been correlated with an increase in vasomotor symptoms, and as well as an increased risk of breast cancer. So, I would consider or encourage you to consider alcohol to be a rarity more than a regularity in that perimenopause and menopause timeframe, and probably for general wellness throughout your entire life. And sleep hygiene. Sleep is vital for hormone balance, and it is vital for recovery and function of a lot of our systems. Our digestive tract is doing its greatest work during those hours of the night. Our brain is both recovering and cementing new memory, creating new memories and storing that. Our musculoskeletal and nervous system is getting rest and recovery. And so this is really an aspect of our lives that is going to have a trickle effect. So improving our sleep hygiene through consistency and ritual, controlling the temperatures in our room, right? The cooler, the better. Utilizing complete darkness. The brain is kind of always on, right? We kind of switch from right lobe to left all night. And if there is light, if there is stimulus, if there is noise, or we're in a new environment, when our brains are switching on and off, they are going to be more alert when some of these facets are can be a trigger. So keeping things cool, keeping it dark, are maybe using white noise are kind of good strategies for sleep hygiene. In addition to what we know, reducing screens, especially in that last 1 to 2 hours of the night, as blue light correlates with reduced melatonin release in the brain. Making sure food and drink is not really consumed 2 hours before your bedtime. And then exposing yourself to morning light is going to kind of kickstart you with your natural circadian rhythm. So I want to just kind of go through this kind of cascade of events. 'Cause these are common symptoms that women experience in perimenopause and menopause. And they can really, when poorly managed, can really start to perpetuate. And think of this as like a flywheel. So as the wheel starts turning, it is picking up speed and contributing to further and further development. So we'll start with maybe increased cortisol. So we have a stressful event, or maybe we have chronic stress in our life. So our body is perpetually releasing cortisol in response to that stress and that stimulus. When that occurs, we see poor sleep, we see poor nutrition, right? Because cortisol is going to stimulate our bodies and our brains to want to consume high fat and sugary content. When that occurs, our body can naturally become insulin resistant, and then we experience weight gain. So when we have insulin resistance, that excess glucose is being is building up in the blood, and our visceral organs, the fat on our visceral organs in our abdomen, have 4 times the receptors for that glucose. So excess glucose will naturally kind of flock to our abdomen, to our visceral organs, and attach to those receptors. And that is commonly why we see the development of excess adipose tissue or abdominal weight gain. With the development of all of these different domains, we see cardiovascular stress, brain stress, we see compromised bone health, and we can see musculoskeletal pains, contributing further to hormone fluctuations and imbalance, and the wheel turns on and on. So while there is some very good research and data to support some pharmaceutical intervention, especially for estrogen hormone replacement therapy, the way we choose to live our lives and the decisions we make every day is going to and can have a profound effect on this flywheel and on our health and on our longevity. So it is really boils down to us making good decisions with these lifestyle factors, trying to live optimally and as our best healthy self, to kind of stop this progression and cascade of events from kind of perpetuating and feeding off one another. All right. In 2018, it was identified that only 25% of women sought evaluation for GSM. GSM is the term for genitourinary syndrome of menopause. It's the name given to the tissue changes that occur in the vulvovaginal region. This can contribute to dryness, to itchiness, painful intercourse, increased daytime urinary urgency, urinary urgency and incontinence, urinary stress incontinence, increased frequency of urination, and increased occurrence of UTI. So while vasomotor symptoms, like we talked about moments ago, will improve and gradually resolve within those 6 to 10 years of our final menstrual period, GSM is not the same. It does not follow that pattern. It is actually progressive in nature. And it's highly occurrent. Up to 84% of women in menopause will experience some of these or most of these symptoms. So why do these changes occur? Why do these symptoms occur? Why are we experiencing them? Because of estrogen, or a deficient level of estrogen. So our genitals, our urinary tract, our pelvic floor muscles, and the supporting tissues in the pelvis are highly estrogen receptive and dependent. That is going to keep the pH of our microbiome nice and acidic to reduce risk of infection. Estrogen is vasoactive, which allows for perfusion and proliferation of blood cells to the local tissue. Estrogen is going to allow for proliferation of the vaginal tissue and maintenance of the rugae, which is the term to describe the inner lining of the vagina. This inner lining and its structure and kind of tissue type is really important because it allows for stretch and compliance and lubrication during sexual stimulation. Estrogen is also going to help maintain an elastic bladder in addition to a thick inner lining. This is going to improve or rather optimize our bladder capacity, because as we drink and the bladder fills, it is slowly and steadily expanding, and that estrogen level is a component of that expansion. And then that thick inner lining is going to keep the bladder from becoming irritated. And then estrogen plays a pivotal role in our urethral resistance or urethral closing pressure. This is a mechanism in place to help maintain continence and prevent urinary leakage. So this is a nice image that kind of demonstrates what the female reproductive system looks like in a estrogen-rich and estrogen-deficient state. You can see kind of in that lower half of the vagina a demonstration of that rugae, or kind of that structure of that inner tissue lining. And you can kind of see the change in the height, or rather the length and the width of the vagina. So when there's estrogen depletion, we will see reduced length, reduced width, relative atrophy of the vaginal tissue. We'll have reduced mucosa of the vulvovaginal tissue as well, which is going to make it more susceptible to injury, as it will not withstand friction and pressure as well. That rugae mechanism will decrease. This results in smoother vaginal walls that won't allow for deformation as well. They'll be much more sensitive and reactive, and this can lead to pain and also some tissue irritation, causing some women to experience bleeding during sexual activity or insertions of various types. Blood flow is going to reduce, and this is going to impact libido and arousal. The microbiome is going to change, which can allow for bacteria overgrowth and contribute to an increased risk of infection. And again, the vaginal fluid viscosity is going to change, contributing to dryness and, again, irritability. So estrogen depletion relative to our urinary function, we're going to lose that elasticity component of the bladder. We're going to lose that thickness of that inner lining of the bladder. Reduced collagen and elastin in the pelvic floor muscles, as well as in the supportive tissues. This can contribute to pelvic floor muscle weakness and also increase a woman's sense of descent or pressure, or symptoms of heaviness, which are correlated with pelvic organ prolapse. And we'll also see an impact on that urethral closing pressure. The muscles of the pelvic floor have reduced fast twitch capacity when they are estrogen deficient, so they won't be able to contract as quickly and as robustly. So think of a quick sneeze or a powerful cough, or a jump, or a quick turn and sprint. These are movements where we need our pelvic floor to respond quickly and with power, and being estrogen deficient is going to impact that muscle's ability to do that well. So pharmaceutical treatment considerations, vaginal estrogen is considered the gold standard for vulvovaginal health and management of genitourinary syndrome of menopause, and it has superior outcomes when combined with pelvic floor physical therapy. So not only does it address the local tissue changes, right, the rugae, the viscosity, the lubrication that occurs, but it's also going to, it's correlated with improving dryness and irritability, improve vascular perfusion, which improves kind of the plumpness of the tissue, which is going to help reduce incontinence, as well as improve libido and sexual health. So this is a treatment that can be utilized via a tablet insert into the vagina, or a cream that is manually applied into the vagina or relative to the urethra, the urethral glands, and kind of the outer vaginal tissue. Or there is a ring insert that is, as you can imagine, inserted and left in place for a period of time. So vaginal estrogen is not systemic. So really it's considered to be safe for most all women to utilize. There have been tremendous studies done across a host of subjects, from non-symptomatic, relatively low comorbidity women in perimenopause and menopause, upwards to women who have a history of various different cancers and diseases. And across the board, again, it's been found to be generally safe for all women. As again, it is not systemic hormone. It is a local hormone that is just going to treat that tissue to which it is applied. It is not going to be able to perfuse into the bloodstream. Non-hormonal strategies for vulvovaginal health, right? I can totally appreciate and respect that some women just don't want a hormonal replacement option, and that's fine because there are some other good options at hand. So vaginal moisturizer with a hyaluronic acid base has been found to be pretty on par with those effects of the vaginal estrogen cream when it comes to addressing painful sex, symptoms of dryness, that itching. It's just not going to have that effect on the urinary function. Application is similar to what we discussed as far as a manual massage. It is applied to the tissue manually and kind of worked in, which is also a really nice time to kind of do some desensitization in the tissue to be a little bit more stimulus tolerant. The other treatments consist of using a vibrator, which have found to be incredibly helpful in reducing local tissue pain, improving blood flow, increasing pelvic floor muscle activation, and improving general health. And then there's some really cool kind of emerging research on vitamin B to help in addressing overactive bladder, urinary incontinence, and improve symptoms of sexual health and satisfaction. So additional non-hormonal strategies. So when it comes to urinary incontinence, urinary urgency, dyspareunia, or think painful intercourse or pain with insertion, and pelvic floor dysfunction, best outcomes are observed when vaginal estrogen cream is combined with pelvic floor training and whole body strength training. So pelvic floor therapy, I think for a long time, was kind of boiled down to learning how to Kegel or receiving perineal massage. And there is an incredible movement really going on right now to kind of rewrite that. And because pelvic floor therapy is so much more than kind of those two kind of mundane ideas or concepts. So everyone presents differently, as most people present differently with musculoskeletal conditions of the knees, the hips, the spine, so on. So no two patients are treated alike. Some women, yes, will need pelvic floor muscle training. They may need strengthening. They may need endurance. They may need coordination training. It depends on how they present, what their symptoms are, and what their goals are. Some women, in relation to pelvic pain or pain with sex, will require maybe more manual treatment, which does consist of internal release work, myofascial release, trigger point. It may uh, indicate the use of different tools, such as vibrators, such as vaginal wands and dilators. For most patients, though, the tide is shifting, and we are working to not only treat those immediate symptoms, but also optimize your overall function. And this is one of the great things about limitless physical therapy, is because we are focused in on that whole body, whole person approach. So yes, we are going to address your pelvic floor dysfunction, but we are also going to look at how you're managing pressure in your abdomen, how you are breathing, how strong your legs are, how good your impact control is, what your load tolerance is for functional movements, because all of those things have a role on your pelvic floor. And then if we think back to those pillars of health, right, we're going to really emphasize how you move during the day and achieving those parameters, what you eat during the day and how that's impacting your symptoms and your progress with therapy, how much water you drink, how you're sleeping, and how you're managing your stress. So I hope that little you know dialogue, it gives you a little bit more or a little bit better picture of what pelvic floor therapy consists of. In a paper I read from 2019, it called "Physical Pelvic Floor Physical Therapy: A Novel Approach," which is so sad, because this is a practice that's been around for quite some time. But it's something that is highly indicated for a lot of these symptoms women are experiencing relative to their reproductive health and perimenopause and menopause. And it's sad to think that in 2019 these treatments were considered novel. And hopefully, we continue to change the tides on that one. So sexuality doesn't end and shouldn't end with menopause. So reduced estrogen is going to impact and reduce libido or desire for sex. It's going to reduce arousal. It can have an impact on reducing orgasm, and there's going to be an impact on painful sex. So there's kind of these four primary facets, and depending on what facet women present with, we in pelvic floor therapy are going to kind of focus in on that. And this is relatively very common. 44% of postmenopausal women are going to experience dyspareunia, or pain with insertion, painful sex. And about 60% of postmenopausal women will abstain from sexual activity altogether due to these long-term vaginal symptoms, which is just incredibly sad, because we have good research and we have good treatment available to address this. So one of the key components that goes along with the kind of pelvic floor direct treatment is the mind-body connection, especially when it comes with painful sex. There's a well-established relationship that after one experience or stimulus of painful insertion, the pelvic floor and the brain store that memory, store that experience. And when it comes to your next experience down the road, removed from that initial one, that relationship and that communication is reactivated. So then our muscles go into guarding, we release cortisol, we become stressed, our sympathetic nervous system kicks in, and we are guarded and apprehensive. And that perpetuates the experience of painful sex further. So part of pelvic floor physical therapy is to kind of retrain the local tissue as well as the brain. So vaginal penetration helps stimulate lubrication. It helps stimulate blood flow, and that's going to improve your arousal and your libido, as well as the local tissue health. So this is where there's a role for manual therapy, for vibrators, vaginal wands, dilators, all with the goal to kind of down train the local neuromuscular system and gradually expose it to stress and stimulus and retrain the brain that the stimulus does not have to be perceived as painful, as harmful, and gradually kind of rewrite that connection. We'll use a progression called sensate focus, where we are gradually helping women return to sexual activity through slow, thoughtful steps with their partner. Some of these steps focus on clitoral stimulation, maximizing foreplay, and the use of lubrication. There's also applications such as vaginal moisturizer, which again will help with that sense of dryness, itchiness, improve senses of pain, and vaginal estrogen cream, which again is a non-systemic that will work locally at the tissue. But generally, when it comes down to it, the concept is to use it or lose it. By using it, by stimulating the tissue, we are creating these physiological processes to take place naturally, which is going to help us in the long term. By not using it, it perpetuates that cycle of pain, of reduced libido, reduced desire, and kind of that stays in place and strengthens until women become non-sexually active. So we talked about some of the pharmaceutical options, which I think is just great dialogue to have with your primary care provider, your gynecological provider, and see, what, based off your symptoms, what are the best options for you in that point of time. But no, there is some good research out there to back up some of those different options. And when it comes to it, the choices you make day to day are also going to have an incredible impact on your perimenopause and menopause symptoms, but also on your wellness later into life. Think about it. If we experience menopause between the age of 45 to 60, we still have relatively about a third of our life to live in menopause. That's a lot of life, and we can live that really well, right? Hitting some of these fundamentals of nutrition, of exercise, of stress management, and sleep. And instead of see our function kind of gradually decline, we can see it kind of go the opposite way, and we can improve our life through those years instead of kind of muscling through them the best we can. It just comes down to the day-to-day decisions that we choose to make. These are all facets that your physical therapist, and especially your pelvic floor physical therapist with Limitless PT, will guide you on and try to optimize alongside of you. So some awesome resources available. The Menopause Society, the National Urological Society, ISWISH, all awesome groups that provide a lot of free education material and some awesome different videos and presentations. Dr. Rachel Rubin, the provider I referenced earlier. She has an incredible presence on her media platforms, and does a lot of great research and education around hormone therapy, vaginal estrogen cream, the genital urinary syndromes of menopause, and sexual health. So she is a great one to kind of tap into, as well as some of these books here, Estrogen Matters and the New Menopause, and again, Limitless Physical Therapy. We have a great group of women who want to support other women in throughout their reproductive life in all stages of life. And we are here to help guide you and walk alongside you in your journey. So please never hesitate to reach out, even if just for a simple question. I think it's so important that we as women just continue to increase this dialogue about these symptoms, about our treatments, because that is only going to drive healthcare and the research for, pregnancy, postpartum health, hormonal health, perimenopause, menopause. It's going to drive that further. So if we do not speak up, and if we do not talk about our symptoms, our experiences, we don't push the needle further. And I think we deserve better than that. So thank you for your time. If anyone has any questions, please feel free to reach out to those of you listening virtually. You can contact me directly via email. Feel free to follow us on our socials to keep an eye on upcoming events and workshops. We have some exciting lineups. So in February, we'll be doing an extended workshop with CrossFit Cortland that will focus on urinary incontinence and exercise. So this will be both lecture-based and kind of hands-on gym-based movements. In March, we'll talk about bowel and pelvic health. In April, we're going to talk about what to expect when you're expecting, what expectant mothers really want to know, versus versus just being told to rest and get your rest now. In May, we're going to talk about pregnancy and exercise. And in June, we'll do another extended workshop on pregnancy and postpartum exercise. So again, please keep your eye out on our socials. And please do not hesitate to reach out with questions, concerns, or if you would like to set up a consult. Thank you for your time. Good night.